It gives me great pleasure now to introduce our panelists for today and our moderator. More details about their backgrounds are in your programs, but let me give you sort of the headline news version. Dr. J. Raymond DePaulo, Jr. is a giant in the field. He is the Psychiatrist-in-Chief at the Johns Hopkins Hospital and one of the world's foremost investigators in the genetic bases of bipolar disorders. He is the author of over 100 scientific publications and 2 books, and he was the guest speaker at the World Economics Forum in Davos, Switzerland, on 2 occasions to talk about the burden of psychiatric disease on national and global economies. Would Dr. DePaulo please come up and take a seat on the panel? Dr. Randy Buckner is a professor of psychology and neuroscience at Harvard University, director of psychiatric neuroimaging research at the Massachusetts General Hospital, and an investigator at the Howard Hughes Medical Institute. A much sought-after expert with hundreds of scientific papers to his credit, he has been invited to speak all over the world about his work in cognitive neuroscience and brain mapping. Would Dr. Buckner please come and take his seat on the panel? Dr. Catherine L. Wisner is the Norman and Helen Asher Professor in Psychiatry and Behavioral Sciences, Professor in Obstetrics and Gynecology at Northwestern University's Feinberg School of Medicine, and Director of the Asher Center for the Study and Treatment of Depressive Disorders. She is the author of over 180 scientific publications and is the principal investigator on multiple National Institute of Mental Health and Foundation-funded research projects, and one of the world's experts on the impact of medication during pregnancy for patients with bipolar disorder. Would Dr. Wisner please come take her seat on the panel? And we're also very privileged today to have Ms. Kate Gaynor-Dickey come and speak as a parent. She is an award-winning senior executive at Marsh USA, an active leader in Chicago nonprofit organizations, ranging from the University of Chicago Women's Board to the Goodman Theater Business Council to the Looking Glass Theater Board of Directors to being the chairman of the board of the executive directors of the Primo Center. However, Kate is here, as I mentioned, not in her professional capacity, but as the mother of a son with bipolar disorder, and she will share her moving personal story with us today. Would Kate please join us at the... And now it gives me great pleasure to introduce our moderator, who is, she makes this day work. And she's done this before for us. She was in Palm Beach with us in January, too. Dr. Ellen Frank. Dr. Frank is one of the true luminaries in the field. She is the director of the Depression and Manic Depression Prevention Center program at the Western Psychiatric Institute and Clinic at the University of Pittsburgh. She is an expert in mood disorders and their treatments. She serves on the Mood Disorders Working Group of the American Psychiatric Association Task Force on the DSM-5, was chair of the Food and Drug Administration Psychopharmacological Drug Advisory Panel, and is an honorary fellow of the American Psychiatric Association. She was elected to the National Academy of Sciences Institute in Medicine in 1999. Would Dr. Frank please come and take over the program?
So no, I'm not going to be checking my email. I'm going to be timing these folks because it is our goal to give you the opportunity to hear a little bit of what each has to say and then open the floor to your questions, which we really view as the most important part of this medical briefing luncheon. I, like Dusty, am not going to spend a lot of time repeating what you can read in your program about each of our panelists. Instead, I'm going to begin by introducing my longtime friend and fellow DSM-5 sufferer, Ray DePaulo. What I think is important for you to know about Ray is that long before any of us got it about how different bipolar disorder was from all the other psychiatric conditions we contend with, Ray got it. He has been one of the most consistent and perhaps the longest lasting researcher in this area. He's going to begin by giving us a general overview of the condition. So, Ray, you've got your 8 minutes, and that's all.
That's right. Well, that's right. Ellen told me that they call this a briefing because I got to be brief, okay? So I want to first thank Joyce and Dusty. It is terrific. It's been terrific to get to know you over the last several years. I want to thank you and the McCormick Foundation for your support for Karen Schwartz, who runs the program at Hopkins called ADAP that you've heard about. Also, I know that this community has met my other faculty member, Kay Jameson, who's been a partner with me for many, many years in this task of trying to understand and explain bipolar disorder. Also want to congratulate Amy and Abby. It's an honor to be on a panel with you because this is a family illness. And actually, Abby, in my genetics research and when I talk to families, I do say that it only runs in the best families, okay? So now I've got 7 minutes, okay? So if I could have my first slide. And my first slide really is, just in case I take too long, the whole talk is here, okay? So I want to make about 8 points. First off, that juvenile bipolar disorder, the name I'll give my talk, it is an early onset illness, but that there's a particular issue with very early onset as well. That's a mixed issue that we may have, and as you know, the diagnosis is purely clinical. We don't have a lab test to back it up, and therefore, every diagnosis a psychiatrist makes is a probability statement, and it's one that luckily and hopefully we reweigh over and over again. The second point I want to make is, well, I've mentioned this, and Ellen mentioned DSM-5, and that's where I'll talk about a sort of alternative classification for very troubled kids who indeed have serious problems, but most of them at least don't have bipolar disorder, we believe now, from follow-up studies. Third point, and I'm so glad that Randy Buckner is here, and I want you to know that I did stay up late last night reading a number of his papers. They are terrific, and we share one slide. But brain imaging, the main topic under brain imaging is that there appears to be a lot of reactivity, no surprise to you all, in the emotional circuitry of the brain. At least those are the early findings, and we're still putting together better experiments. In the genetics work, there are now 30 identified genes. Okay, now we used to be wondering, when are we going to get one? When are we going to get one? Okay, and as soon as I stopped doing grant work in this field, we found 30. Okay, so I don't know. Now 30 is a lot, and we'll talk about that for a minute. Okay, but this is, if you will, with the brain imaging work and the genes, we can't put the story together yet, but we've got a parts list. It may not be a complete parts list, but that's really important. If you're going to try to build something, you want to have a parts list. Okay. Next point I want to make is that treatment medications, especially lithium, but also other medications, are very helpful, very important, especially for the severe bipolar 1 patients. And, you know, we couldn't, as we say, don't leave home without it. We couldn't treat our severely ill patients without these medications, okay? But equally important, and this is a point where I got to refer back to Ellen Frank, is that treatment is a partnership. And that, if you want to think about the thing I talk to parents about the most, it is your child, your husband, your daughter, your parent, they need to be a partner in treatment, okay? And the hardest part of that is accepting that, yep, this isn't just me having my moods, this is an illness. And that the doctors are not perfect. We're going to make mistakes, but the best way we can correct those mistakes is to see you over and over again and to know you across a long period of time. And then lastly, this partnership also implies one other thing, and that is that, if you will, lifestyle, if you will, or behavior is critical. And IPSRT stands, you probably know this in this room if you know Ellen Frank, interpersonal, social rhythms treatment. Did I say social? It's not social. Is it social?
Interpersonal and social rhythms
it is.
therapy.
There you go. All right. See? And I didn't even give her the microphone. All right. so that, and the point is there that you're really trying to get people to understand that I've got this illness. I've got to change certain things that I need to do to decrease the risk of relapsing with this illness. Okay, and so that's part of the acceptance deal. Equally important, maybe just as important, maybe more important for some patients. No illicit drugs. Alcohol is quite dangerous, and in particular, in 2014, we need to say that cannabis, marijuana, is a danger to our patients with bipolar disorder, and a serious one. So let me see how many slides I can get through here, okay? All right, so early onset, bipolar illness is an early onset disease for all the patients who get it, for the most part, okay? The median age of onset, that means 50% of the patients who get it in a lifetime will have it by the time they're 17, at least in our family studies, okay? And very early onset, under the age 13 is not rare, but it's also not very common. And it's associated, when we see it and we confirm it as best we can, that with very strong family history. Usually the patients I've seen in those very early ages have the illness in both parental lines, okay? It has a more difficult course of illness, okay? Early onset bipolar disorder is by its nature a more difficult form of the illness, okay? And then, but it's very important to mention also that there have been concerns now that maybe we overdid it. When I started in psychiatry in the early 70s, I only diagnosed one case of bipolar disorder in my first year, seeing 200 patients, okay? That's because no one taught me how to do it. We weren't good at it. I did spend some time in England. I did learn how to come back, do it, and I found out that half of my psychotic patients had bipolar disorder because I took kind of obsessive notes, okay? I did meet one on the first day I got back from England, and I could see her coming down the hall. I didn't know she was running, and she really liked me, I guess, because as I diagnosed her with schizophrenia, she leapt on me, knocked me to the ground, giving me a kiss, okay? I said, I think this is one of them, okay? All right. So bipolar illness is an early onset condition. 3, 2.
No, you've got 2.
2. Oh, boy, okay. It's an early onset illness. If you can make out this here, this is 20 years of age. The 2 big bars are occurring 15 to 20 and 10 to 15, okay? That's when most patients get bipolar 1 or bipolar 2. Okay. The increased rate of diagnosis of bipolar disorder in children from 1994 to 2003 went up 40 times. We don't think that we probably had 40 times that many cases of bipolar disorder, okay? So it's important to know what your child has. It's important to know what they don't have. It may take a few visits. It may take some time. Thirdly, there's this classification that was created called disruptive mood dysregulation disorder. It says that these kids have lots of mood problems, lots of behavior problems, but they probably don't have bipolar disorder. And there's research coming out every day that supports this notion, okay? Fourthly, okay, brain imaging. I like genes, but trying to go from genes to the clinical condition is a Hail Mary pass. You better go through the brain, okay? And this is work of Mary Phipps from Pittsburgh, where Ellen is from. And the red areas show you areas of the brain that appear either kind of bigger or smaller and over-connected to each other. And these are kind of the main parts area in the brain that have to do with mood circuitry, okay? So this is being defined, and the experiments are getting better. Okay. Last, I told you there were 30 genes now involved. They haven't all been published yet. They will be. The kinds of genes, luckily we can put them in families, are regulators of calcium transport as one set of the genes, synaptic integrity, the synapses that connect one nerve cell to another, and neuronal growth factors all seem to be important. We've got a long ways to go. We're now using different methods. That'll come next. Lastly, treatment, it's a partnership. That's the most important thing I can tell you. Treatment medications, especially lithium, are important. About half the people that take lithium for a lifetime will say that it totally changed their life. The other half will say, no, it didn't totally change my life. Most of them will feel improved. Some will not. And then lifestyle is critical. We've already talked about that. We've got to live a life. We need to have exercise. We need to eat right. We need to sleep right, which Ellen's therapy works on. But we also need to avoid illicit drugs, alcohol, and cannabis, regardless of what state you live in. I think that's it. Thank you very much.
So I just want to inform all of you who may not be aware of this, you've just witnessed a miracle. I think it's the only time I've ever been on a panel with Ray where he actually made it on time. So, Randy, you are not an old friend. I was hoping that you would become an old friend last night, but the air traffic control system conspired against us. So I'm really looking forward to hearing what you have to say, and I hope by the end of the day we'll be old friends.
I just want to add my thanks to Joyce and Dusty, who are inspiring in the pursuit of what is something that many of us share in common and need to change the world in this arena. But through your own personal efforts, I think those you've come in contact with, I think it's just caused us to refocus, invigorate us, and just wanted to thank you for organizing this and for having me here. What I wanted to talk today about is as much about our progress, and I guess if you have the projector switch over, great. Oop. Just have to change this for a second. There we go. Is in much part about the discovery of what might be the causes and ways of changing bipolar disorder as much as removing stigma. We now have a number of tools of ways of looking into the healthy brain and also in the brains of individuals with mental illness that actually allow us to peel back and understand what is the most remarkably complicated organ, not just in our bodies, that one can imagine. Hundreds of billions of cells talking to one another with trillions of connections that, because of a miracle of evolution and a good handshaking between our genes and the typical environment, evolves in ourselves into something that can allow us to do many incredible mental faculties. It's not surprising that sometimes it goes awry and that there are imbalances that lead to mental illness. We now have tools to see in the brains of individuals and to understand some of that circuitry. What you're seeing here is actually now a very common technique that looks at the white matter pathways in bundles. I put it up here just also to show you just how beautiful the brain is. Because we were talking about some aspects of it that go awry. I just want to start by saying it is really a remarkable structure that we need to understand, both because of the applications of this understanding, but also because of what we can learn. And so I wanted to tell you a little bit about what we've learned. We've learned about some of the key brain systems involved in emotion. You heard some of these alluded to. We know that, for example, there are structures buried deep within the brain called the amygdala, and other structures that help us with our drives. And these are the systems that are good to have, and when they're functioning, motivate us to do what we do. Some of these systems are what we help us to experience pleasure, to get us to move towards and re-engage those things that are good for us. Other systems, such as the amygdala, are ones that give us signals that we feel is very aversive. They help us to be afraid of things and move away from things, and in a social world, change our behaviors when things aren't working. We've learned that we can activate these tremendously in very simple manners by placing an individual in a scanner, for example, and showing them emotional faces. It's remarkable. Alfred Hitchcock knew this, that the scariest thing you can do is show somebody's expression of fear and not showing them what is causing the fear. That kind of face will drive the amygdala tremendously. And we know that this circuitry, these drives and these emotional circuits, are in balance with systems that control them. And so here I'm showing you this one set of structures called the amygdala. It projects and sends information to a broad range of regions across the entire cerebral cortex, both directly and indirectly. And what I'm showing here to the right are some of its target zones, its direct target zones in a monkey brain. We don't know exactly where these are in the human, but we can estimate it from the monkey. And what we think is that in healthy function, in normal moods, what we see is a balance between these emotional circuits that are driving us and motivating us, and also these control systems. And as you saw from the beautiful work of Mary Phipps that was illustrated in the last talk, this is complicated. There's a number of brain regions. They're acting as networks, and they're controlling our emotional circuits. And so rather than try to go into any of these details, I wanted to give you a metaphor. I liken this to what you see here in this picture. This is Napoleon going into battle. And there's an important thing to notice in this picture of this galloping horse, is there's two things happening. Napoleon is using his feet and the stirrups to drive the horse forward into battle. But at the same time, he's using the reins to control and steer this magnificent beast. Our brain is the same way. Our emotional circuits drive us forward and motivate us through our lives, but we also have our cortex, our prefrontal cortex, and complicated circuits that are in balance that are helping to steer this. We think that in mood disorders and in bipolar disorders, that balance is lost. And there might be many ways in which that balance can be lost, and we're just learning now how to see that in the brain. For example, if you take a group, and this is something we did, and take a group of 1,000 college-age students, you'll find that amongst those students that have symptoms of mood disorders, you can see that the amygdala, and these are 18 to 20-year-olds, is structurally enlarged. And this is an important finding, not because it hones in on the structure, it also reminds us that this is circuitry and wiring in the brain. And I think one of the most important features of removing stigma is to help people understand this isn't a battle of will. These are changes in the brain in circuitry that's already wired when you're a young adult, and we have to take that into consideration both for how we think about this, but also how we treat it. You can also see there are changes in the control circuitry that we think regulates these emotional systems. There's a study that was done just down the road here, at the University of Chicago, where it was shown that these kind of emotional phases will trigger in all of us responses in these reactive circuits in the brain. If you look at individuals with pediatric bipolar disorder, about 15 years old, what you'll find is that these systems are hyperactive, again suggesting that something about the balance between the control of these emotional circuits and their reactivity has changed. And the final thing that we've learned is this is complicated. There's not just one circuit controlling other circuits. Here's actually a map that was made from 1,000 individuals using another technique, functional MRI, of one network in the brain. And it's actually asking what is connected to this region here. This is just a projection of the outer surface of the brain, the cortex. Here's the front of the head, and here's the back of the head. What I'm going to do is actually animate this small region right over here, and you're going to see the networks of connection change as you go from one part of the brain to another. This is actually in all of us. These are the broad networks that are connected. We have large distributed networks that connect multiple parts of our brain, but they seem to make an interwoven patchwork of these networks. And we think it's through the workings of these networks and how they work with each other and their interactions that allows us to be flexible, allows us to control our emotions and use them when we need them and to suppress them when we don't. What we've learned is that many features of mental illness probably occur because of the breakdown and subtle breakdowns in the interactions of these networks. And we can see that. For example, I'm not going to go into any details here. If you take 3 of these networks, large networks that all of us have in our brain, you can actually measure and make a map of their interactions. And that's what's shown here in a group of healthy, normal individuals who don't have any symptoms of a mood disorder. If you now make that same kind of connectional map, and this is a map of how these brain networks are talking to each other and interacting, you can see that there's a change in the psychotic phase of bipolar disorder. And we don't fully understand what this means yet, but what we do think is it's telling us that the networks and the balances of these networks across the brain are, in some sense, becoming disjointed. But critically, these are periodic events, we think, and there are periods when this kind of disorganization is present and other periods when it's not. And we think that's a huge opportunity. And so the last point I want to make is that I showed you what I hope are some indications that we're making headway in seeing what we think are some of the causes of bipolar disorder and how typical brain function is altered and maybe even some hints of how we might alter it back. But what I want to do is stress that we actually haven't done the most important thing. Everything I showed you was in groups of individuals, sometimes 1,000 individuals. We pooled information from 1,000 people's brains to get insight into what's different. What we need as a field to do is hone everything in on the focus on the individual. And we're just now coming up with tools where we have enough technical savvy to make these measurements in an individual so that we can predict and we can understand better, because while this is a complicated from the get-go, we think it's even more complicated because no 2 of us are alike. There's no 2 individuals. Even 2 individuals in the same family with bipolar disorder can be very different from one another, and the same person over time has experiences that are very different from one year to the next and even sometimes 1 month to the next. And we need to understand the individuality, and we need to turn these tools rather than at groups of individuals to the individual person to make forward progress. Thank you.
So thank you, Randy, for taking what is indeed an incredibly complex area of research and in 8 minutes making it perfectly clear. Thank you. So now it's my pleasure to introduce someone whom I have known for longer than I think either of us would care to admit. Kathy Wisner has really devoted her career to understanding the specific needs of women and girls who have mood disorders. And that's been particularly challenging around the issues of reproduction, which has been her primary focus. So, Kathy, it's my pleasure to welcome you to this medical briefing and to give you your 8 minutes. And that's all.
Right. All right. Well, thank you so much for the introduction. And I would also like to thank Joyce and Dusty for inviting me to share this incredible experience with you all. So, as Ellen mentioned, I'm going to be talking about reproductive events, and in particular, bipolar disorder in girls and adolescents and young women. So I thought the best way to illustrate the points that I want to make were to actually take off on Randy's point about the individual. So I'm going to share with you the story of Sandy, who is a young woman that I've followed for about 15 years now, sort of emphasizing Ray's point about the importance of following people long term. So Sandy was a grade A or an A student in grade school, did very well until she started her periods at about age 12. At that point, her family wasn't sure if what they noticed, which were episodes of being very active, being very creative, not needing a lot of sleep, followed by many days in bed. This was their first child, so they thought Sandy was having a normal adolescent reaction. Until, at age 14, she made her first suicide attempt and was hospitalized. She was put on an antidepressant as a solo drug and said, I just took that medicine so I could get out of the hospital. But she described feeling activated, agitated on the antidepressant, came out, made another attempt, and was hospitalized again. Sandy's course after that was very difficult. She got into the goth subculture, dyed her hair black, and there was one aspect of what Sandy did, though, that was very special, and that is she's sort of an animal whisperer. She would take baby birds, nurse them back to health. In the stable where she rode horses, there was a stallion that nobody could manage except her. So she had this sort of intuitive, special caretaking skill that did allow her to become employed in a pet shop. Now, sadly, though, Sandy had the comorbidities that we typically see with young patients with bipolar disorder. She developed bulimia, had DWIs, and then became addicted to heroin. Her family lost her for about a year. She had no address. They weren't sure where she was. And during that time, I was in touch with the family for support. They reconnected with Sandy when Sandy was finally arrested for driving getaway cars for her male partner thieves who were stealing to feed the drug habit. And what happened then was the parents were at the hearing and Sandy was newly pregnant, and the very wise judge sentenced Sandy to prison for the duration of her pregnancy. So I'm going to move on to a couple other topics, but then bring you back to Sandy and tell you what happened. So one of the areas of interest I have is perinatal psychiatry and treating women during pregnancy, postpartum, premenstrually, and perimenopause. But I'm also a child psychiatrist by training. And this type of information where we know that the prevalence of depression in females versus males rises to twice the level. So it's a ratio of 2 to 1, females to males. And that happens right around puberty and lasts for the remainder of the reproductive years. So one of my great interests is potentially then developing a menarche clinic, because we forget that part of the reproductive life cycle in most of our work in women's mental health. I also will briefly go over some of my attempts to understand how adolescent girls who are mothers understand about their illness, understand about motherhood. So I did a whole series of focus groups to interview these young women mothers to find out what they thought about it, how they understood being mothers. What was really interesting is that in these focus groups, when we analyze the transcripts and you look at, well, what is the topic of the conversation? 35% of the conversation focused around social support and how they were struggling to figure out how, in the context of their social milieu, what they perceived as positive and negative social support. And I think it speaks to what we've heard already and to some of Ellen's work, that the social support, the situation with the milieu is critically important. And interestingly, despite the fact that these girls all had mood disorders, many of them had bipolar disorder, the word depression was not in the transcripts. Everything was perceived as a reaction to some event in the interpersonal milieu, which was a real comeuppance for me, where I'm primarily a biological psychiatrist. It was a real comeuppance for me about the importance of multimodal therapies for these young patients. And just a quick quote from one of the patients is on the bottom. Sometimes my mom will say, well, you had a baby, you're old now, da-da-da-da-da. And sometimes she'll be, oh, well, you're only 17, so da-da-da-da-da. And her point here was an appreciation of her mother's ability to encourage her and push her towards this developmental stage of mothering that she was in, but sometimes give her slack and recognize that she was only 17. Getting back to Sandy. Sandy illustrates many of the difficulties we have in treating young bipolar patients. Detection and diagnosis, we really need that test to figure out diagnoses. And the challenge of figuring out what's normal adolescent behavior around puberty and what is distinctly abnormal is a difficult task, and we certainly need more work in that area. Treatment engagement for Sandy was in prison. That was the treatment engagement. She adamantly refused to take any medication because of that difficult experience she had after her first inpatient admission. Treatment delivery was also in prison. She was pregnant, but with consultation, she received lithium during her pregnancy. She remained stable in pregnancy and delivered a healthy baby girl, and I'll show you more about that in a minute. Symptom improvement was dramatic, and when Ray was talking about the patients who respond to lithium, this was Sandy. She became a model prisoner, much as she had been a model student in her early childhood years. So let me tell you now about her improved outcomes. And I show you her picture and her children with her permission. Sandy is stable. She has terminated her relationship with the father of her children, who is a methamphetamine addict. She is now back in school studying to be a paralegal because she wants to try to understand and help other girls. But she's writing an autobiography as her own therapeutic exercise to understand what happened to her. And I spoke to her recently, and her question to me was, what can we do to make sure that what happened to me doesn't happen to baby Eva? Thank you.
Thank you, Kathy. Excuse me. It's now my pleasure to introduce Kate Gaynor-Dickey, who combines her tremendous professional expertise with a truly moving story of personal experience and does it brilliantly. So please join me in welcoming Kate.
Thank you, Ellen. Thank you. Well, good afternoon, everyone. And thank you for allowing me to tell you my story today. I'm the mother of Spencer. He's 26 years old, and he's my only child. And he's 4 years sober today. And I have to say, it just feels really good to be here and to be able to be here before you today and say that. For those of you who have been affected with bipolar disorder, you know the road is not easy. In fact, it can be a long, dark, and sometimes a very lonely one. I was like every other parent out there. I was filled with hope and optimism for my child's future. I was engaged in my son's activities. I interacted with other parents. I was involved in his school, sport, and community activities. But even at an early age, Spencer seemed a little different. But I thought it was all part of him developing his personality. As our children grow, we become observant of the many changes that take place. Moodiness, less communication, more independence, stronger social connections. As they go through adolescence and begin growing into adults, oftentimes they are reacting to the day-to-day pressures of their environment. When you start to question their behaviors, you start to question yourself. Am I overreacting? Am I paranoid? Is this a phase they're going through? I'm sure it'll pass. In Spencer's case, it was different. He had intense bouts of anger, temper tantrums, and mood changes that lasted for periods. Initially, it was diagnosed with attention deficit disorder and later on with depression. My reaction was one of relief. This explains what's wrong with my son. But I soon realized there were no real changes. And his behavior and the progress that I expected was not happening. Call it a mother's intuition. Deep down, I knew there was something seriously wrong with Spence. We continued to visit doctors and continued to get the same answers, which only made me more frustrated. What do I do? Where do I turn? I felt completely helpless, and it started to tear me apart inside, knowing my son needed help, and I could not give it to him. But I refused to give up. I set out on a quest to find out what was wrong with Spencer and to get him the help he needed. This was easier said than done. I spoke with countless medical physicians and passionately telling my story, only to be told there was nothing medically wrong with my son. Remember, there is no blood test or brain scan that can diagnose bipolar disease. I sought out the best doctors I could, even consulting a neurology specialist, only to have my hopes dashed as I got the same answer. Things didn't improve, and I became more worried as Spencer went away to college in West Virginia. Secretly, I hoped that change of the environment, new friends, new opportunities, new learnings might be the catalyst for some progress or change. However, things got worse. He was diagnosed with depression and a learning disability and was prescribed a cocktail of medications: Adderall, Xanax, and Paxil. Maybe this is it, I said. Things will change, I thought, but no relief. In fact, things got worse. Addiction got the better of Spencer, and sadly, he took matters into his own hands and started to self-medicate. He combined all of his prescribed medications with a plethora of street and other prescription painkillers that formed into a toxic mix that only complicated his condition even further. At that time, I had no idea what was going on as he battled his demons on his own. It was no surprise that his health was now in a state of serious decline, a drug addict that had exhibited bounds of extreme anger and violence for prolonged periods. I still question, was this now the drugs that were making him behave like this? Or was there still some underlying cause that had not been detected? Again, I believed in my heart there was something wrong with Spence, something we didn't know about. I gathered my strength yet again and pushed on, never for 1 minute wanting to give up. And deep inside, I was torturing myself. Where did I go wrong? Is it my fault? Did I miss something? What could I have done more? Why is this happening to Spencer? My left-handed pitcher, star basketball player, my son. Was it my divorce? Did my executive career and ambitions play a part in this? Should I have been around more? There were no answers, only more questions, and Spencer continued on a path of despair and me searching for answers. I became obsessed in finding out what was wrong with my son. Underneath the medications and the illicit drugs, I knew there was something fundamentally wrong that was yet to be diagnosed. At this time, I took a job that meant I had to relocate to Chicago. Little did I know that this would be the pivotal point in my son's life. At the same time, I was invited to the Ryan Light Saying Foundation Early-Onset Bipolar Medical Briefing Luncheon as a guest of Helen Malachor. Helen, thank you. And Cheryl Dyer. Dr. Kay Redfield Jameson from the Johns Hopkins Mood Disorder Center, and Janet Wozniak, MD from Harvard Medical School and Massachusetts General Hospital, were the keynote speakers. As the proceedings got underway, I listened intently to what was being discussed, and to my complete amazement, I could not believe what I was hearing. Chills came over my whole body, and they were describing Spencer, his behaviors, his temperament, his moods, and his action. And I sat here in the same room 4 years ago, stunned in silence. I couldn't believe it. Finally, could this be it? Is this what Spencer is suffering from? Does he have bipolar disorder? I was elated and then turned to terror as my mind and heart started racing. What does this mean? What happens now? What's the treatment? Can he be cured? But at last, some hope. A ray of sunshine in what had been such a very dark cloud. Then, another turning point, and one that set a new path and direction for Spencer and I. Spencer didn't know it at the time. The Ryan Light Saying Foundation co-founders, Dusty and Joyce Sang, introduced me to Dr. Janet Wozniak, one of the country's foremost experts in the disease. Dr. Wozniak immediately offered to help, and for the first time in many years, I felt a sense of relief that someone really understood what was happening and could offer some positive steps and solutions. I remember Janet's first words to me. Spencer is seriously sick. For the next 18 months, working through and with the foundation, I had weekly calls with Dr. Wozniak, who was based in Boston. These calls were not just about how to help Spencer, but they were also about preparing me to help deal with what we had to go through. I also continued a continued friendship, guidance, and support of Joyce and Dusty. I became empowered, knowledgeable, and strong, and I was ready and prepared to help Spencer deal with his demons. Exactly as Dr. Wozniak predicted, it got worse before it got better. After a near-fatal overdose, I received a frantic call from Spencer, who was in a New York jail, alone, scared, and sick. He was charged with 3 felonies and clearly at the lowest point in his life. Now was the time to act, and to act quickly. With the wonderful help of Joyce and Dusty, Abby, and the foundation, I was able to secure a place for Spencer at Hazleton Youth and Family Foundation directly after jail. His journey back to being well again had started. Finally, I thought, finally. All of these years, there was an answer. My instincts were right. My son had a serious illness that no one could diagnose despite all efforts, but he was now in a safe and healing environment. However, there was yet another issue I had to deal with, and after 4 months of Hazleton, it was determined that Spencer was not well enough to come home. He went on to the Grey Wolf Ranch, Port Townsend, Washington, to continue his treatment plan for another 6 months. Now, being a single parent, I have to tell you, a rehabilitation program does not come cheaply. And I had to find a way to pay for Spencer's treatment. We had come too far not to go forward. So I used my ingenuity, and I sold most of my jewelry, and I decided to borrow from my 401k to raise enough money to pay for the treatment. Finally, I felt we were going to come through this, but I still had a deep fear that it might not work. Once again, I never gave up, and I pushed on, and we had come too far to look back. As I stand here before you today, I am beaming. I'm beaming because, as I said, Spencer is 4 years sober. His symptoms are under control. He has a wonderful job at Champs in St. Paul, Minnesota. And I am proud to say that he's the #1 sales manager in the country. Kind of like his mom. And he just got promoted to the 3rd largest store in the Northeast. So. Thank you, Ellen. So ours has been a complicated journey with many twists and turns. It's not an easy road dealing with bipolar disorder, as many of you know in this room. I was driven by my love for my son, my determination to find out what was wrong with him, my deep desire to see him whole again, to see him happy and healthy and enjoying life. I learned many things from this journey. And most importantly, never give up. As Winston Churchill once famously said, when you are going through hell, keep going. And I did it, and it paid off. Thank you. Thank you. Thank you. Thank you. Thank you.
Thank you.
And finally, and most importantly, without this foundation, Joyce and Dusty, your unwilling support, your tireless encouragement, your passion for the cause, your love and support, I would not be standing here today. I am Kate Gaynor. I am Spencer's mom. Thank you.
So now I'm going to take the chair's prerogative and editorialize for a moment. If we never find the test, just think about how many lives Joyce and Dusty have saved by their willingness to talk about their experience, by their willingness to help other people find the help they need, and by their incredible drive to tell the story of bipolar disorder as you have heard it in all its aspects this afternoon. So we are, in fact, at 1:30. Where's my boss? Dusty, shall we take a couple questions, or shall we give folks who need to leave an opportunity to leave? Dusty, I need some direction. Okay, Joyce, I need some direction.
We promised that the program would be done by 1:30. It is. If any of you have to go back to work, please feel free to leave. But the doctors, our wonderful doctors, are going to stay 15, 20 minutes more for Q&A. So I hope most of you will stay, but if you have to leave, we totally understand. Thank you.
So, as people are getting up and moving, we do have folks around the room with microphones. Who would like to ask a question of any of our panelists this afternoon? We need that first brave soul.
Here we go, over there.
Okay.
My question's for Catherine. Is lithium during pregnancy a recommendation for all cases, or was that just a recommendation for that specific case?
Yeah, Corinne, thanks for the question. Lithium is a primary drug that we use for bipolar patients, and I chose that particular medication for Sandy in part because she had relatives who were good responders, so that was one consideration. But the other was that in jail, she was in a structured setting, and that I could monitor her lithium levels and her doses very carefully across pregnancy because the metabolism of the drug changes, so you have to be very careful about titrating the dose to the serum level. So that's why I selected it, but you're absolutely right. There are many challenges in using medication for pregnant women, but we're making great progress understanding both the risks and the benefits. And in her case, it was really a life-saving treatment, and her little baby Eva's wonderfully developing, as is Robbie, the second child, who's also lithium exposed.
Yes, right here.
We know so little about the brain. You clearly are doing lots of research on it. What research are you seeing out there that is interesting, groundbreaking, maybe a precedent to something else?
It's a big question. What do I see out there that's groundbreaking and interesting? And just to pick two different, I think, very important breakthroughs or sort of themes that the field is undergoing. One has to do with how we look and explore the kind of circuits at the lowest level, at the levels of the molecules in the cells themselves. There's been a huge arsenal of new tools that we can use in animal systems, such as mice, to make what we think are models of some features of human disorders. And it's important to always remember it's only some features. And the reason why that's so critical is it allows thorough exploration of what might change these features in pharmaceutical companies and in laboratories. And so there's a new set of tools that we're seeing at the level of animal models, mouse models of disease. The other place where I think we're seeing a sort of a catalytic event is that the techniques that I mentioned, the brain images and maps that I showed, I think it's very poignant to some of the really nuts and bolts issues that we're confronting day to day, is that we can see generally what bipolar disorder looks like in the fictitious average person. But we can't help an individual. We can't scan a 15-year-old to suggest that, well, this child is depressed, don't give Prozac. This is likely bipolar disorder. We don't have any test to do that simple thing. And so with a number of technological advances, some of you may have heard there's a large push by the NIH, the National Institutes of Health, something called the Connectome Project. We actually have just a huge step up, a catalytic event in technologies that a number of laboratories are actually turning to not understand more and more about the fictitious average brain, but focusing them completely on the individual to see how far we could push, because we know this is going to be needed for forward progress understanding the illness, but also ultimately for the clinic.
So on a note of optimism, just to underscore what Randy just said, I think the animal models that we have used to develop treatments particularly for mood disorders, until recently have been exceptionally poor. They probably really aren't models of our diseases, but I would say that probably the best animal model we have at the moment is a model of a manic mouse. When you ask, does this animal have not just one, but 4 or 5 features of bipolar disorder, the answer is yes. So I think that's a real step up and a real opportunity for us to make progress. Now what we need is a good model of the depressive side of the illness. Other comments or questions? Yes, please. Changes in the DSM-5, right?
Okay, boss. Ellen was at least the den mother of DSM-5, at least for the mood disorders. I think the ones that probably matter the most are is what we talked about here, is have the kids have a diagnosis, at least a grouping, tentative as it is, to say, look, these are kids with real serious troubles. That they don't appear, most of them, to have bipolar disorder, that DMDD thing that I showed. And actually, there was a paper just published yesterday from the Smoky Mountain Project, Dr. Costello and company, who we know well. And she indeed has been able to go back and look at records, be able to diagnose this in people that she saw 20 years ago and look many years out. And indeed, most of them look like they do not have bipolar disorder, but they are really troubled kids. And so she argues that maybe by luck we came up with a category that'll work and be useful for those. So that's probably the biggest change.
I'd mention one other.
Yeah.
The primary criterion for diagnosing mania up until DSM-5 was a distinct period of abnormally elevated or irritable mood. All the emphasis was on mood. And part of the reason that it takes all these years to get the diagnosis right is that kids don't show up when they're hypomanic. Kids show up when they're depressed. So we think they have depression, we treat the depression, and we make the bipolar disorder worse. What we did in DSM-5 was require a distinct period of abnormally elevated or irritable mood and a distinct increase in activity or energy as the primary criterion. What this means is that when someone sits down with a 17-year-old depressed kid, if you ask about mood, the mood changes that go with bipolar disorder are what we call in our trade egosyntonic. It feels like a part of yourself. It's syntonic with who you think you are. But if you ask someone about distinct changes in activity or energy, not only is the person more likely to remember that, but other people can actually observe it. You can see those changes in activity and energy. You can't see the changes in someone's mood. So we're hopeful that bringing this change in activity and energy up to the first question that we ask when we're thinking about a possible bipolar disorder may really help in the retrospective diagnosis of bipolar disorder.
If I could add one other thing that really goes right along with that, and that is that because the area I spent a lot of, I was in sort of spearheaded, and that is that the best evidence now is that antidepressants do not make kids just with depression manic, and they don't make normals manic. So that the fact that you went on an antidepressant and became manic, we reverted back to the old practice of saying these people probably have what we believe is bipolar disorder. I think that's important. The preponderance of evidence is strongly in favor of that conclusion as well.
Yes.
I have 2 questions here. Oh.
Okay, well, go ahead.
I have a question for Dr. Wisner. And I don't know if you can make a general statement, but what is your advice to the parent of an adolescent girl with early-onset bipolar disorder who's being treated with medication as you prepare for the onset of menstruation?
Yeah. It's a good question, and there's not a lot of research data, but certainly from a clinical standpoint, when these young girls reach puberty, it's a time of major brain remodeling changes, and it's a challenge, but I also see it as an opportunity so that, the kinds of life skills and health skills that one would teach, I think, are particularly important, as are education about sexuality, because some of the young bipolar girls become hypersexual during these hypomanic manic episodes, and I think it's critically important to talk with them about sexuality and birth control as well. But the approach that I sort of kind of listen to the lessons of my patients where although medication is an extremely important part of the treatment plan, using those adolescent changes and the need for skill building and greater cognitive capacity, I use a lot of more skill building treatments, even some of the DBT basic skills, so that my sense is I want to prepare them for being able to structure those interactions which are so important around them in a positive way and not be derailed by negative interactions. So, and just to finish, I've been very frustrated in a way with my postpartum work, which I love, but all the postpartum women that I see say, well, this started in my childhood, in early adolescence, and I've now become frustrated and thinking, well, I was intervening early in the lives, well, maybe of the children, but not for these women. So moving further back in the life cycle, I think life cycle is critically important.
Thank you. I have one other quick question, and this is for the two gentlemen. Dusty Sang told me last night about two concepts that are new to me, the plasticity and pruning of the brain. And I'm very interested in this. Could you talk just a little bit more about these two concepts and how the parents of children with bipolar can adapt their parenting around these ideas?
You got to start.
So it's a great question. Also, another big question that we don't have any specific answers to. What we've come to appreciate is, and this is something that differs between us and our closest cousins, the chimpanzees, is just how much plasticity and for how long it's been expanded out. So the human niche, sort of the remarkable thing that we're able to do is pass on information generation to generation, teach each other things, whether that was simple tool building, but now all the things of our complicated world and our brains are plastic all the way up through our 20s, literally. The physical wiring and the way it matures isn't complete until you're in your 20s, and this is a good thing. It also means that in adolescence, you have opportunities. I think that was a great way to frame it as an opportunity, but also a sensitive period that needs to be dealt with. And so I can't say more than we've learned and have many markers to show that these plasticity windows are open literally for decades before they're shut down. But maybe you can comment specifically on how it interacts with bipolar.
Well, I'm not sure I can. All I can say, though, is that it does remind me that the brain develops not based just on the genome, but it develops based on what the circumstances are. And one of the, I think, underappreciated areas, and newly appreciated areas would be epigenetics, so-called epigenetics, how the both internal and external world influence the expression of genes. But also, simply put in a different way, it may operate through epigenetics, is the power of culture. And I think that's very important. And so that the culture in which our kids are raised does matter. And I think the fact that their school children, their classmates now may learn more about these illnesses and know what we know as well as what we don't know could be very important to us. So I think that's the only way we can kind of move forward right now.
So there was a question here at the front. You got your question answered? Okay. Back there, do I see someone tentatively raising her hand? No?
Can I add, Ellen, could I bring in you? Because I really want to talk about, with this idea of plasticity and health education, The IPSRT and the principles of circadian regularity on health, I think, are absolutely crucial, and I find them very appealing to adolescents. So can you talk a bit about that?
Yeah, we're actually doing a study at Pittsburgh of children who are at high risk for bipolar disorder by virtue of having a parent with bipolar disorder. And we are teaching them the principles of interpersonal and social rhythm therapy, even though none of them yet has bipolar disorder. They might have an anxiety disorder, they might have had an episode of depression, but they've not yet been diagnosed with bipolar disorder. And interestingly, you would think that when you tell a teenager what's going to be really good for you is to go to bed at the same time every day, to have dinner at the same time every day, and I'm talking about weekends too, that you're going to get tremendous pushback. But actually, we found the reverse. Yeah. And that is that for these children who, whether they admit it consciously or just have it as some lurking thing in what Sigmund Freud referred to as the unconscious mind, they are worried about getting bipolar disorder. So when you say this is something that you could do that might help, if not prevent, at least delay the onset of this illness, they're remarkably adherent. It's shocking how willing these young people have been to make changes in their lives. The other thing that really surprised us is that these children who do not have a diagnosis, how interested they are in talking about their interpersonal problems and the link between their interpersonal lives and their schedules. So we've been very surprised and become remarkably hopeful about the possibility of intervening in children at risk. Ray, you look like you want to say
I think
something.
this is great, and that's one of the points I was really trying to make in my comments. But these are special children that she's treating because they've had, pardon the expression, I think it's important, the advantage of seeing the illness in their parent. And I think we've got to do that. We've got to make an opportunity here with that. And I think that is a great hook for the kids, is to say, look, mom has this, dad has this, I don't want you to have it. I can't guarantee this will stop it, but hey, look, this is something you're going to need to do. Okay.
So we'll see. I mean, we're a long way away from knowing whether this really does do anything to prevent or delay the onset of the illness, but at least we've learned that young people are willing to do this, and that gives me some hope.
Yeah, I've often had parents come to me actually and ask about issues of having children. I've got bipolar disorder. Should I have children? And I talk to them about what their other reasoning is and everything else. And I say, well, look, if you have a child and they get bipolar illness, these are usually people that are quite well adapted. God forbid, I said, they could come out just like you, be a bank president, be a lawyer, be a mom, be a grandmom. I said, and the other thing is, the biggest problem we have is the delay in diagnosis. And I don't think any child of yours is going to go 10 years without somebody saying, does this child have bipolar disorder? So those are real life examples. I think those are things that we can really do.
So I can see we're getting toward 2 o'clock. If there's one last comment or question, we'll take that. And yes, way back by the column there.
Thank you. This is just generally to the panel. I know alcoholics, there are many who are very high functioning. They can do everything, and they're diseased. They have a lot of problems. And I was wondering, with bipolar, are there many people who are very high functioning? They don't take their medicine. They do not do what they're supposed to do, but they function. And they basically get by. They maintain, in other words. Do you find this to be true on any level, or will eventually you will have your disaster waiting to happen?
Well, I'll be happy to take a shot at that. I used to try to count the number of bipolar patients I'd seen, but I can't count them anymore. So, and the answer is yes, there are. This is a very strange illness in that it, in its classic form, is episodic. It comes and goes. And, of course, it varies enormously in how frequently it'll come back and in how long you'll be ill and how severely ill you'll be. So, yes, I've seen people in their 60s or 70s who have had several episodes of illness and haven't, they may have been in a little treatment a little bit of the time. I certainly have seen people who gave up alcohol and did 10 times better off alcohol than they did on, even if they wouldn't take treatment for it. So the answer is yes, but it is a real roll of the dice, shall we say? And I sit behind at a big institution, so that I might miss some of those people too. So, Kathy sees a lot of these folks.
Yeah, it's a really interesting question, and I do see a lot of these folks. And where I see them is in pregnancy, where the struggle is against alcohol and the use of alcohol in pregnancy, which people know is not a good thing to do. But what I sometimes see are women who are more comfortable using alcohol or marijuana because they're not prescribed, and they perceive lithium or the drugs we use as really powerful drugs. So there's so much information and education that has to occur around medications. And the reality is, for the medicines that we use as mood stabilizers, there are a fair number of side effects, and they have to be very carefully monitored. So, I try to work with these women to balance what we know about the medicines and the mood stability against their choice of substance use in pregnancy. But you're right, it's a very difficult situation, and sometimes they perceive using alcohol, particularly at bedtime, even though it actually disrupts sleep, they'll say, well, the alcohol puts me to sleep. So there's a lot of countering some of the ways of thinking towards more education and better decision-making, better choices.
So at this point, I want to thank what has been an unbelievably attentive audience.